Welcome to the deep dive. If you're a specialist clinician navigating the ever-evolving landscape of managing thrombosis and vascular disease, whether it's in arteries or veins, you know how critical it is to stay sharp on the latest evidence. It's a field that's constantly changing based on new trial data.
It really is. And keeping up with every single study, every subtle shift in recommendations, it's a massive undertaking. Trying to synthesize that volume of information and then apply it clinically. That's the real challenge.
That's exactly where we come in. Today, we are doing a deep dive into a really significant document for anyone involved in vascular care, the European Society for Vascular Surgery 2023 Clinical Practice Guidelines on Antithrombotic Therapy for Vascular Diseases.
Right. And this isn't just another guideline. It's actually the first time the ESVS has put out a guideline specifically dedicated solely to antithrombotic therapy across that whole broad spectrum of vascular conditions. It was published in the European Journal of Vascular and Endovascular Surgery. Lead authors Christopher P. Twine, Stavros Kikakos, and others, and it truly represents a huge multidisciplinary effort. I mean, the writing committee brought together experts from angiology, phlebology, cardiology, clinical pharmacology, interventional radiology, vascular medicine, and vascular surgery.
The stated purpose seems really clear: to help clinicians and patients importantly choose the best antithrombotic strategy. And these guidelines cover a vast array of arterial and venous conditions you see day in and day out in a vascular department.
Now, they did set some boundaries, which is important to note up front. While they cover extensive arterial and venous territories, they explicitly state that intracerebral and coronary arteries were beyond their primary scope. Though, understandably, data from key trials in those areas, sometimes they're referenced when they're relevant to systemic atherosclerosis.
So how are we going to navigate this detailed document in our deep dive? We're going to essentially use the guideline itself as our map, right? We'll start by looking at the foundational aspects, like, how do we measure the effect of these medications?
Yeah, the basics.
Then we'll dedicate significant time to antithrombotics for patients with arterial disease, exploring different vascular beds from carotid and upper limb to renal and mesenteric, and a really deep dive into the lower extremity, including management around procedures.
And we'll also cover the non-atherosclerotic conditions too, and specific arterial problems like embolism and aneurysms, even arteriovenous fistulas and grafts.
From there, we'll pivot to the venous side, covering prophylaxis, deep vein thrombosis, superficial vein thrombosis, cancer-associated VTE, interventions, and venous malformations.
And finally, we'll wrap up by discussing specific patient populations that often present unique challenges, like those with chronic kidney disease, cancer-associated arterial events, patients who already have another indication for antithrombotic therapy, and even that tricky area of thrombophilia in arterial disease.
The methodology behind these guidelines is worth mentioning, isn't it? Because it really underpins the strength of the recommendations.
Absolutely. They followed rigorous agree reporting standards, had a dedicated writing committee working intensely, went through multiple review rounds, including external peer review by, I think, 19 experts, and required approval from the ESVS Guideline Steering Committee. And where high-level evidence was, a bit scarce, they leaned heavily on consensus-driven recommendations.
They even commissioned a specific study just for these guidelines, the development of the OAC3 peripheral artery disease score, right? Aimed at improving bleeding risk assessment.
That's right, improving that risk stratification.
Understanding the grading system is absolutely crucial for interpreting the recommendations. They use a modified European Society of Cardiology system.
Yeah, so evidence is graded level A, B, or C. Level A is from multiple randomized trials or meta-analyses. Level B, from single randomized trials, large non-randomized studies or meta-analyses of non-randomized studies. And level C is based on expert consensus, small studies, retrospective studies, or registries.
And the recommendations themselves are graded by class. Class 1 meaning the intervention is recommended.
Yes, strong evidence, general agreement, it's beneficial.
Class 2A meaning it should be considered.
So the weight of evidence or opinion is in favor.
Class 2B meaning it may be considered.
Usefulness is less well established there.
And Class 3 meaning it is not recommended.
Not useful, maybe even harmful. And throughout this deep dive, for every major recommendation we discuss, we will explicitly state its specific class and level. So you'll hear us say Class 1, Level B, or Class 2B, Level C.
Exactly. For you, the specialist clinician listening, this deep dive is crafted to be highly applicable. We're not just summarizing, we're going to elaborate on the key recommendations, the rationale, the specific trial evidence or lack thereof, and the clinical nuances you need to factor into your daily decision-making.
Right. Think of it as unpacking the why and how behind the guidelines, not just, a checklist of what to do.
Because at the heart of antithrombotic therapy lies that fundamental, often difficult balance, preventing potentially devastating thrombotic events, strokes, heart attacks, limb loss, PEs against the inherent, sometimes life-threatening risk of causing bleeding with these powerful medications.
Yeah, and the guidelines constantly wrestle with this trade-off. They acknowledge the real-world challenges too, like inconsistent definitions of bleeding used across different trials, which makes comparison hard.
And the difference between those carefully selected trial populations and the complex patients we actually see in our clinics?
Absolutely. And managing modifiable bleeding risk factors is itself a core recommendation. It's Class 1, Level C. While predicting exactly who will bleed remains challenging, addressing known risks like uncontrolled hypertension or a history of peptic ulcer disease, or managing INR carefully for those on vitamin K antagonists, it's paramount.
The guidelines mention proton pump inhibitors, right?
Yes, they say proton pump inhibitors should be considered. That's Class 2A, Level C for patients with a history of upper GI lesions or other higher bleeding risk factors. The idea is to help reduce that risk of gastrointestinal bleeding.
All right, so consider this your detailed roadmap for the next while. We're going to systematically work our way through these guidelines, starting with measurement techniques, then tackling the vast landscapes of arterial and venous diseases, specific patient groups, and finally looking ahead at the critical areas where more research is needed.
Okay, let's dive in.
Okay, let's jump into Section 3, Measurement of Antithrombotic Effect. This section explores how we monitor the impact of these medications, both to ensure they're, therapeutic and to assess potential overeffect that could lead to bleeding.
Right, and they divide this naturally into patients who are not undergoing an intervention and those who are post-intervention.
So for patients not undergoing intervention, the main focus seems to be on the international normalized ratio, the INR, standard stuff for warfarin.
Absolutely. And the evidence here is just foundational, isn't it? It's consistent across decades of use. Letting INR values get too high is unequivocally linked to an increased risk of major bleeding. So the guidelines just reinforce the necessity of careful INR management to stay within that target range.
Now, what about antiplatelet function testing in the stable, non-intervened group? We hear about high on-treatment platelet reactivity. Does the guideline say we should be testing for this routinely in stable PA to patients?
That's a really common question. And it's an area of active research, for sure. But based on the evidence the guideline committee reviewed, their conclusion is pretty clear. For stable peripheral artery disease patients who are not undergoing intervention, there's just no clinical evidence right now to support the usefulness of routine antiplatelet function testing.
So even though you can measure it.
Exactly. High on treatment platelet reactivity is a real phenomenon. You can measure it, but its direct relationship to clinical events in that specific stable population hasn't been convincingly shown to warrant routine testing or, more importantly, changing therapy based on the results.
So you have a patient with claudication, stable on aspirin. We don't need to send off a test to see if the aspirin is working in terms of platelet reactivity to guide our therapy for their claudication.
That's precisely the guideline stance. The data doesn't support using that test result to inform your management decision in that stable setting.
Okay, let's shift to the post-intervention setting. This is where platelet function testing often seems more relevant, especially thinking about coronary stenting. What's the take here for PAD interventions?
Well, the guidelines discuss findings from some specific studies, often, extrapolated from non-cardiac surgical settings that happen to include vascular patients. For instance, one prospective study using thromboelastography looked at platelet reactivity with ADP receptor inhibitors like clopidogrel. And interestingly, it found that low on-treatment platelet reactivity, meaning the drug was working very effectively, was actually predictive of a higher peri- and postoperative bleeding risk.
Right, that seems counterintuitive. You'd think low reactivity is the goal to stop clots.
Exactly, but it just highlights that tightrope we walk. While high reactivity might link to thrombotic risk, getting too low reactivity seems to link to bleeding risk, especially around surgery. Another study also linked low on-treatment platelet reactivity to a higher risk of major bleeding and needing transfusions in non-cardiac surgery.
The guideline also brings up perioperative aspirin resistance.
Yeah, one study found it in about 30% of patients having open or endovascular interventions. But interestingly, in that particular study, this finding wasn't associated with myocardial injury, and it didn't address whether actually changing the antiplatelet based on detecting resistance would make any difference to outcomes.
So given these findings about potential links between platelet reactivity and bleeding post-intervention, Does the guideline actually recommend using these tests to guide therapy? Say, switch from clopidogrel if reactivity is too low.
Despite being able to measure these things, and despite those observed correlations, the overall conclusion from the guideline is pretty much the same as for stable patients. The source states there is simply not enough data available right now to recommend stratifying bleeding risk using platelet reactivity testing, or to recommend changing specific antiplatelet agents based on the results after PA intervention.
So we can measure platelet function, and some studies show these correlations, but we lack that robust evidence showing that acting on these tests actually improves clinical outcomes, either reducing clots or reducing bleeding, specifically in the PAD population after intervention.
That's the bottom line for now, based on this guideline. The clinical utility for routine guidance just isn't established yet.
Okay, let's move on to heparin monitoring for patients on unfractionated heparin infusions.
Right. For continuous infusions, the guideline issues recommendation 4. This is a strong one. Class 1, level C. It recommends monitoring the activated partial thromboplastotime, the APTT, or the APTT ratio. And the stated purpose is specifically to reduce the risk of bleeding. It's based on consensus and long-standing clinical practice, supported by studies showing the importance of keeping patients in the therapeutic range.
Why level C evidence, though, if it's such standard practice?
Yeah, it's often the case for these really fundamental, long-established practices. You just don't have big, recent randomized trials comparing, say, monitoring APTT versus not monitoring APTT for heparin infusions. It'd probably be unethical. So the evidence comes from observational data, historical controls, expert consensus, which typically falls into level C.
Makes sense. So monitoring infusions is standard. What about bolus doses, like during an arterial procedure?
Yeah, in the OR or the angio suite, particularly during open or endovascular arterial surgery, the activated clotting time, or ACT, is commonly used. It's a point-of-care test, so you get a result much faster than waiting for a lab APTT. The guideline does note that ACT doesn't correlate quite as strongly with the actual heparin concentration compared to a lab APTT, but its speed makes it really useful for guiding those bolus doses in the moment.
Is there good research on what the optimal ACT target should be in non-cardiac arterial procedures?
Well, a recent meta-analysis cited in the guideline looked at this, and it basically highlighted a lack of robust data, and consequently, no strong consensus on the optimal ACT target specifically for non-cardiac arterial procedures. However, the meta-analysis did find that ACT seemed to correlate with surrogate markers for both thromboembolic events and bleeding in the trials it included.
Which leads us to recommendation 5, I suppose.
Exactly. Recommendation 5 is Class 2B, Level C. It states that monitoring using APTT, APT ratio, or ACT may be considered for patients undergoing open or endovascular arterial intervention who get a bolus of unfractionated heparin. This is based on consensus and that limited correlation data.
So just to clarify, monitoring UFH infusions is a clear Class 1 recommendation, but monitoring periprocedural boluses with ACT or APTT is a weaker Class 2B recommendation, reflecting less certainty about the targets and impact.
Precisely. It acknowledges its common practice, but notes the evidence for driving specific outcomes based on monitoring boluses isn't as strong.
And what about monitoring low molecular weight heparins?
Low molecular weight heparins, or LMWH, are typically monitored using factor XI levels if monitoring is needed. The source notes that trough factor XI levels, so measured just before the next scheduled dose, seem most appropriate for assessing their activity.
But is routine LMWH monitoring recommended for PAD patients?
The guideline explicitly states there's insufficient data in the literature to provide clear recommendations on monitoring low molecular weight heparins, specifically in patients with peripheral artery disease.
Okay, let's do a quick micro recap on this measurement section then. Routine monitoring of antiplatelets using function tests, or LNWH using factor XI, isn't strongly recommended for KIK patients based on current evidence, whether they're stable or post-intervention. However, monitoring unfractionated heparin infusions with APTT is recommended. Class 1. Monitoring UFH boluses periprocedurally with ACT or APTT may be considered Class 2B. And for vitamin K antagonists like warfarin, INR monitoring remains absolutely essential.
That neatly wraps up Section 3. Ready to move into the big section on antithrombotics for arterial disease?
Absolutely. But maybe first, let's do a quick mega recap just on that measurement section. Key points. INR monitoring for warfarin is critical. For antiplatelets, routine platelet function testing isn't currently recommended for PAD patients due to lack of evidence that acting on results improves outcomes. For unfractionated heparin, monitoring infusions with APTT is Class 1, while monitoring intraprocedural boluses, ACT or APTT, is Class 2B. And routine monitoring of low molecular weight heparins for PI isn't specifically recommended due to lack of data, though Factors I is the test if needed for other reasons.
Got it. Okay, on to Section 4, antithrombotics for patients with arterial disease.
Right, this is where we get into the nitty-gritty of managing different vascular territories. The guideline starts by defining peripheral artery disease, or PA, quite broadly encompassing atherosclerotic disease from the aorta down to the toes, but also including upper limb, visceral, and cerebrovascular atherosclerosis. And chronic, or stable, just means anything that isn't acute limb ischemia.
Let's start at the top then. Section 4.1, atherosclerotic carotid artery disease. The guideline recognizes, of course, that both asymptomatic and symptomatic carotid stenosis carry a significant risk of future stroke.
For asymptomatic patients with carotid stenosis, the focus is on reducing overall cardiovascular risk. What's the recommendation for antithrombotics here?
Recommendation 6 is a strong one, Class 1, Level B. It recommends aspirin, usually 75 to 100 milligrams daily, for patients with asymptomatic carotid stenosis. The primary goal here is secondary prevention of broader cardiovascular events, MAC, essentially not necessarily targeting the stenosis itself. This is backed by Level B evidence from big trials and meta-analyses like the Antithrombotic Trialist Collaboration, the Asymptomatic Atherosclerosis Trial, and POPDAD, which show the general cardiovascular benefit of aspirin in patients with atherosclerosis.
So standard secondary prevention with aspirin. What if a patient can't tolerate aspirin?
Good question. If aspirin isn't tolerated or is contraindicated, then recommendation 7, which is Class 2A, Level C, suggests you should consider clopidogrel 75 milligrams daily as an alternative single antiplatelet agent. It's a reasonable alternative based on its profile, although the evidence specifically for this indication is Level C.
What about dual antiplatelet therapy, DAPT, aspirin, plus clopidogrel for asymptomatic carotid stenosis? Is more better here?
No, not according to the guidelines. Recommendation 8 is clear and it's Class 3, Level C. It does not recommend dual antiplatelet therapy for asymptomatic carotid stenosis. The rationale is basically a lack of proven benefit in this lower risk setting, combined with the known definite increase in bleeding risk with DAPT.
And anticoagulation, is that ever used just for asymptomatic carotid disease?
Even stronger recommendation against that. Recommendation 9 is Class 3, Level A. It does not recommend anticoagulation for asymptomatic carotid stenosis. This is based on high-quality evidence, especially the WAVE trial, which included some patients like this and clearly showed a significant increase in bleeding risk with anticoagulation, without any demonstrated benefit for preventing arterial events in this population.
Okay, so for asymptomatic carotid disease, single antiplatelet is standard, aspirin preferred, Class 1. Dual antiplatelets are out, Class 3. And anticoagulation is definitely out, Class 3.
That's the summary. Now let's turn to symptomatic patients. These are patients who've had a recent TIA or a minor stroke attributed to their carotid stenosis. They're at a much higher immediate risk of a recurrent, possibly major stroke. So this requires more urgent and sometimes more intensive antithrombotic therapy.
What's the first line recommendation for someone presenting with symptoms?
Recommendation 10, Class 1, Level B, recommends aspirin 75 to 325 milligrams daily as first-line therapy for symptomatic carotid disease. You want to get antiplatelet protection on board quickly.
And if aspirin isn't an option for them?
Recommendation 11, Class 2A, Level C, says you should consider clopidogrel or the combination of aspirin plus topiramate if the patient is intolerant to aspirin or allergic.
Now, this is where dual antiplatelet therapy becomes really important, but it's for a specific limited time frame, right? Recommendation 12.
Exactly. Recommendation 12 is a very strong Class 1, Level A recommendation. It recommends dual antiplatelet therapy with aspirin plus clopidogrel or aspirin plus topiramate specifically for patients presenting with a minor stroke or a high-risk transient ischemic attack. And crucially, this intensive therapy should only be given for a short duration, 21 days, followed by single antiplatelet therapy thereafter.
And that's backed by some big trials.
Yes, robust Level A evidence from pivotal trials like ESVS2, eSprint, Chance Point, and Thales. These trials clearly demonstrated that this short course of DSPD significantly reduces the risk of early recurrent stroke during that initial highest risk period, right after minor event.
What are the alternatives for that 21-day dual therapy if clopidogrel is an issue, say allergy or intolerance?
Recommendation 13, Class 2A, Level B, suggests you should consider dual antiplatelet therapy with aspirin plus ticagrelor or aspirin plus topiramate in that situation. This gives alternatives based on other evidence, like the Thales trial with ticagrelor.
Now, for patients undergoing carotid endarterectomy, CEA, after being recently symptomatic, is there a specific aspirin dose recommendation around that?
Recommendation 14, Class 2A, Level B, suggests you should consider aspirin 300 to 325 milligrams daily for 14 days, followed by lower maintenance doses like 75, 162 milligrams daily. This regimen is thought to reduce recurrent stroke risk around the procedure. It's based on evidence like the ACE trial, which compared different aspirin doses before CEA and found higher initial doses were reasonable, or that lower doses might be similar if maintained.
Let's just elaborate a bit more on the evidence for DAPT in symptomatic patients not immediately going for surgery or those waiting. The guideline mentions trials comparing aspirin plus dipyridamole versus aspirin alone, like ESPS2 and ESPART.
Right. Those showed the combination was effective for secondary stroke prevention and could be started early. But then they also highlight the PROFESS trial, which compared long-term aspirin plus dipyridamole versus clopidogrel monotherapy after stroke. PROFESS found no significant difference in long-term efficacy, which suggests that prolonged dual therapy isn't necessarily better than just using long-term clopidogrel alone for overall secondary prevention after the initial high-risk phase.
And the guideline also touches on trials looking at aspirin plus clopidogrel versus aspirin alone in relation to those microembolic signals you can detect on TCD.
Yes, citing studies like CARES and AMBD. These showed the combination could reduce microembolic signals, which are seen as a marker of ongoing stroke risk. So that provides some mechanistic support, alongside the clinical outcome trials like CHANCE and POINT, that provided the direct evidence for the short-term DAPT benefit. And an audit mentioned also highlighted that recurrent events often happen before the CEA can be performed, which really reinforces the need for effective medical therapy right away after symptoms start.
It really emphasizes that vulnerability in the first few weeks after a TIA or minor stroke.
Absolutely. That's why the focus is on immediate and sometimes that short-term intensified antiplatelet therapy.
Now, let's look specifically at antithrombotic therapy around the time of carotid intervention, both endarterectomy, CEA, and stenting, CS.
Recommendation 15 is a very strong Class 1 Level A. It recommends antiplatelet therapy before, during, and after both carotid endarterectomy and carotid artery stenting. This reflects the universal understanding that you need continuous antiplatelet coverage to minimize thromboembolic risk around these procedures.
And for CEA specifically, what's the preferred agent?
Recommendation 16 is Class 1 Level C. It recommends aspirin 75 to 325 milligrams daily as the first-choice antiplatelet agent before, during, and after carotid endarterectomy. This is largely based on standard clinical practice and consensus.
For carotid artery stenting, CAS, the strategy is a bit different because you've got a foreign body, the stent, in place.
Exactly. So recommendation 17 is Class 1 Level C. It recommends dual antiplatelet therapy with aspirin and clopidogrel for a minimum of 4 weeks after carotid stenting. Then, after that initial DAPT period, they recommend continuing clopidogrel 75 milligrams indefinitely as single antiplatelet therapy to reduce long-term stroke risk. It balances the early stent thrombosis risk with the longer-term systemic risk.
So short-term DAPT, then long-term single therapy with clopidogrel after stenting. What about just continuing DAPT long-term after CAS?
Recommendation 18 is Class 3 Level A. It does not recommend long-term dual antiplatelet therapy after carotid stenting. This is based on Level A evidence showing no additional clinical benefit beyond that initial period and, importantly, a definite increased risk of bleeding.
Looking ahead to preventing future cerebral and cardiovascular events long after these interventions or symptomatic events, the guideline kind of circles back to those trials like ESPS2, CAPRI, ESPRIT, PROFESS, CHANCE, POINT, DELIs.
Right, and points out that while those trials inform the initial high-risk management, they often didn't specifically study or give data on de-escalation strategies after the recommended DIP period, or compare long-term single agents head-to-head in these exact post-event or post-procedure populations. So there's still some nuance there about the optimal long-term single agent after de-escalation.
Okay. And finally, let's explicitly hit anticoagulation again for atherosclerotic carotid disease. We mentioned the WAVE trial for asymptomatic patients, but it's broadly relevant, isn't it?
Hugely relevant. As a reminder, WAVE randomized patients with various arterial diseases, including carotid, to a full-dose vitamin K antagonist plus aspirin versus aspirin alone. The outcome was stark. No difference in major cardiac or limb events, but the combination group had a highly significant, nearly twofold increase in major bleeding, particularly life-threatening bleeding. The hazard ratio was 1.96.
Which really cements why Recommendation 9, Class 3, Level A, strongly advises against using anticoagulation for asymptomatic carotid stenosis, and generally for atherosclerotic carotid disease, unless there's another compelling reason, like AFib.
Absolutely. The bleeding risk just clearly outweighs any potential benefit for the carotid plaque itself.
Yeah. The guideline includes Figure 1, which is a really helpful flowchart summarizing all this for atherosclerotic carotid artery disease. If I describe it quickly, it starts with asymptomatic versus symptomatic. Asymptomatic leads to single antiplatelet, aspirin class 1, clopidogrel class 2A, and class 3 against DAPT anticoagulation. Symptomatic branches to CEA versus CA-CLAN, or neither. For high-risk CAM or stroke not getting intervention, it shows DAPT, aspirin plus clopidogrel class 1, for 21 days, then single. For CEA, antiplatelet recommend class 1 throughout, aspirin first choice class 1. For CAS, DAPT, aspirin plus clopidogrel recommended for at least 4 weeks post-procedure, then single clopidogrel indefinitely class 1, with long-term DAPT explicitly not recommended class 3. It also has important footnotes defining symptomatic high-risk TIA and high bleeding risk. It's a great visual summary.
That was a comprehensive run-through of carotid disease. Let's do a quick micro recap on the key points. For asymptomatic carotid stenosis, single antiplatelet for secondary CV prevention, class 1, DAPT and anticoagulation not recommended, class 3. For symptomatic disease, minor stroke, high-risk TIA, immediate antiplatelet is key, including a recommended 21-day course of DAPT, aspirin plus clopidogrel or aspirin plus dipyridamole, class 1, then single therapy. Around carotid intervention, antiplatelets recommended throughout, class 1. After CAAD, aspirin plus clopidogrel recommended for at least 4 weeks, then long-term single clopidogrel, class 1. Long-term DFT after stenting is not recommended, class 3. And anticoagulation is generally not recommended for atherosclerotic carotid disease alone, class 3.
Perfect summary. Now let's move laterally and look at section 4.3, atherosclerotic upper limb arterial disease.
Right, asymptomatic upper limb disease, like finding a subclavian stenosis incidentally. While these patients probably have systemic atherosclerosis and might have been in broad trials like asymptomatic atherosclerosis or POPIDAD, there's a real lack of specific evidence on antithrombotic therapy tailored just for isolated asymptomatic upper limb disease. And the actual cardiovascular risk associated just with that asymptomatic upper limb finding, separate from disease elsewhere, isn't really well described.
So, given that lack of specific data, what about patients who have chronic symptomatic upper limb disease, like arm claudication?
Recommendation 19 is Class 2A, Level C. It says you should consider using single antiplatelet therapy for chronic symptomatic upper limb arterial disease. The main goal here is secondary prevention of cardiovascular events, basically extrapolating from how we manage symptomatic atherosclerosis elsewhere. It's based on expert consensus, Level C.
And if you revascularize an upper limb artery, say with a stent or bypass?
Recommendation 20 is Class 1, Level C. After revascularization for upper limb atherosclerotic disease, the guideline recommends an individualized antithrombotic strategy. You really need to carefully balance the risks and benefits for that specific patient, aiming to reduce both secondary cardiovascular events and limb events like graft occlusion. It's a strong recommendation, Class 1, because it's clinically important, but it's based on consensus, Level C, due to the lack of specific trials in the upper limb comparing strategies. It emphasizes tailoring the approach.
Okay, micro recap on upper limb arterial disease, limited specific evidence. For chronic symptomatic disease, single antiplatelet should be considered. Class 2A, Level C, mainly for CV prevention. Post-revascularization, an individualized strategy balancing risks and benefits is recommended. Class 1, Level C.
Let's move down now to section 4.4, atherosclerotic renal and mesenteric arterial disease. Finding atherosclerotic lesions in these arteries is strongly associated with increased systemic cardiovascular risk. And renal artery stenosis, of course, can also cause hypertension and contribute to CKD.
But again, similar to the upper limb, there's a notable lack of specific evidence from RCTs looking at antithrombotic therapy, specifically in this population, right?
That's exactly right. So recommendation 21, Class 2A, Level C, states you should consider single antiplatelet therapy for patients with symptomatic atherosclerotic renal or mesenteric artery disease. Again, the primary goal is secondary cardiovascular prevention, and the recommendation relies on consensus and extrapolation from managing symptomatic atherosclerosis elsewhere.
What if one of these vessels gets revascularized, like a renal artery stent?
Stent thrombosis is definitely a concern there. So recommendation 22, Class 2A, Level C, suggests you should consider a short course of dual antiplatelet therapy after revascularization for atherosclerotic renal or mesenteric artery disease. The recommended duration is a minimum of 1 month up to a maximum of 6 months using aspirin 75 milligrams and clopidogrel 75 milligrams. This is specifically for patients not judged to be at high risk of bleeding, and the rationale is to reduce that risk of stent thrombosis. It's based on consensus, balancing the local stent thrombosis risk against the systemic bleeding risk of DAPT and limiting the duration.
Got it. Micro recap on renal and mesenteric arterial disease. Single antiplatelet should be considered for symptomatic disease for CV prevention, class 2A level C. A short course of DDT, aspirin plus clopidogrel, should be considered post-revascularization in low bleeding risk patients, class 2A level C, to reduce stent thrombosis risk.
All right, now we arrive at the big one, section 4.5. Atherosclerotic lower extremity arterial disease, this is, highly prevalent, increasing in incidence, and associated with significant morbidity and mortality risks of death, major adverse cardiovascular events, AFE, and major adverse limb events, MALE, like ALI, CLTI progression, or amputation.
Let's break this down by presentation, starting with asymptomatic patients with lower extremity TAD, maybe an incidentally found low ADI.
Okay. Recommendation 23 is class 2A level A. It states you should consider single antiplatelet therapy for secondary cardiovascular prevention in patients with asymptomatic lower extremity arterial disease, particularly if they are judged to be at high overall cardiovascular risk. This is based on level A evidence from large trials like the Antithrombotic trialist collaboration meta-analysis and the POPADAD trial. While the absolute benefit in asymptomatic patients might be smaller than in symptomatic ones, the evidence supports considering it in those with significant other cardiovascular risk factors.
Okay, now for chronic symptomatic patients, those with claudication, for example.
For this group, the recommendation is definitely stronger. Recommendation 24 is class 1 level A. It recommends single antiplatelet therapy for secondary cardiovascular prevention in patients with chronic symptomatic lower extremity arterial disease. This is fundamental, strongly evidence-backed level A from multiple large data sets and trials.
And is there a preferred single antiplatelet agent?
Yes. Recommendation 25, class 2A level B, says you should consider clopidogrel 75 milligrams daily as the first choice single antiplatelet agent for secondary cardiovascular prevention in chronic symptomatic lower extremity PA. This preference for clopidogrel over aspirin as the single agent comes mainly from a subgroup analysis of the CAPRI trial. CAPRI compared clopidogrel to aspirin overall, and the paid subgroup seemed to potentially derive more benefit from clopidogrel.
So just to be clear, Class 1 says use single antiplatelet therapy overall, and Class 2A suggests clopidogrel is likely the best single-agent choice based on that CAPRI subgroup.
Exactly. Now let's talk about dual antiplatelet therapy, DAPT, in this chronic symptomatic paid population. Should we be adding a second antiplatelet?
The guidelines review evidence from trials like Charisma, specifically that post-hoc subgroup analysis in symptomatic paid, and also systematic reviews and umbrella reviews that pool data on DDT in chronic symptomatic LEAs.
And the conclusion is really consistent across all these analyses. Dual antiplatelet therapy, usually clopidogrel plus aspirin, has not shown a significant reduction in major adverse cardiovascular events in chronic symptomatic lower extremity paid. But it has consistently shown a significant increase in the risk of major bleeding. Table 7 in the guidelines summarizes this really well, showing that unfavorable risk-benefit profile for routine DAP for secondary cardiovascular prevention in this group.
So the increased bleeding risk just doesn't come with a clear payoff in terms of preventing heart attacks or strokes in these chronic PA patients.
Precisely, which leads to a strong recommendation against using it routinely. Recommendation 26 is Class 3, Level B. It does not recommend dual antiplatelet therapy for secondary cardiovascular prevention in chronic symptomatic lower extremity arterial disease. The evidence clearly shows the increased bleeding risk outweighs the lack of benefit from MAHAD-E. Any potential benefit just from MAL alone is often not enough to justify the overall harm from bleeding.
What about triple antiplatelet therapy? Does that ever come up?
The guideline notes a significant lack of studies specifically looking at triple versus dual antiplatelet therapy in patients with lower extremity arterial disease. Most of the triple therapy data we have comes from, ACS or coronary stenting.
Okay, so single antiplatelet is the standard for chronic symptomatic PA. What about anticoagulants or combination therapy? Full-dose anticoagulation, usually with a vitamin K antagonist, has been looked at. The WAVE trial comes up again here.
Yes, WAVE is key again. It randomized patients with various arterial diseases, including PTA, to either full-dose vitamin K antagonist, targeting a high INR of 4.5, though time and range was only about 50%, plus aspirin, versus aspirin alone. And as we saw with carotid disease, the safety results were concerning. Table 7 summarizes it. The trial found no evidence that the combination of full-dose VKA plus aspirin was superior to aspirin alone for preventing major cardiovascular or limb events.
But critically, it showed a clear threefold increase in the risk of life-threatening bleeding with the combination.
So combining full-dose anticoagulation with an antiplatelet for chronic symptomatic PA is generally a bad idea due to the bleeding?
Absolutely not recommended based on wave A. The bleeding penalty was just too high without a clear efficacy gain. However, the guideline then introduces the combination of aspirin plus low-dose Rivaroxaban 2.5 milligrams twice daily based on the pivotal COMPASS trial.
COMPASS enrolled patients with stable atherosclerotic disease, including a large P cohort.
That's right. The primary endpoint for COMPASS was a composite of cardiovascular death, MI, or stroke. And the trial found that the combination of aspirin plus low-dose Rivaroxaban significantly reduced this primary MA outcome compared to aspirin alone. And really importantly for vascular specialists, it also significantly reduced major adverse limb events compared to aspirin alone.
That sounds like a win, but was there a downside? A bleeding trade-off?
Yes, as always with antithrombotics, there was. The reduced ischemic events came at the cost of an increased risk of major bleeding. Though, importantly, the trial did not show an increase in fatal bleeding or bleeding into critical organs. So the overall assessment in the trial population was a net clinical benefit.
But it's crucial to remember the COMPASS population, isn't it? They had specific exclusion criteria for high bleeding risk, which are listed in Table 8 of the guideline.
Absolutely critical point. The trial population was selected to be at relatively low bleeding risk compared to many real-world PD patients we see. The guideline even points out that real-world data suggests maybe only around 30% of hospitalized PED patients would actually meet the bleeding risk criteria used for eligibility in trials like COMPASS or Voyager. That really highlights the challenge of applying these results broadly.
And there's also the issue that COMPASS didn't directly compare aspirin plus low-dose Rivaroxaban head-to-head against clopidogrel alone, which we just established as the preferred single agent.
Exactly. That direct comparison is missing. A network meta-analysis tried to compare the available data indirectly, including the COMPASS results. It found no statistical superiority for the aspirin plus low-dose Rivaroxaban combination over clopidogrel monotherapy for the primary composite cardiovascular endpoint in the chronic lower extremity arterial disease subgroups.
So without that head-to-head trial, how does the guideline position these two strategies, clopidogrel alone versus aspirin plus low-dose Rivaroxaban?
Well, based on the available evidence, COMPASS showing benefit versus aspirin alone, but the lack of proven superiority over clopidogrel alone in indirect comparisons, the guideline concludes that both clopidogrel alone and aspirin with low-dose Rivaroxaban are considered reasonable choices for secondary cardiovascular prevention in chronic symptomatic lower extremity arterial disease.
Which leads us back to Recommendation 27.
Recommendation 27 is a strong Class 1 Level B. It recommends clopidogrel 75 milligrams daily as the first-choice single antiplatelet agent for chronic symptomatic lower extremity arterial disease when single antiplatelet therapy is indicated for secondary cardiovascular prevention. This basically elevates the earlier Class 2A recommendation based on Carotid to Class 1, reinforcing it as the go-to single agent if you choose that path.
So if your risk assessment leads you to decide single antiplatelet therapy is the right strategy, clopidogrel is recommended as the agent of choice.
Precisely. Now, let's consider specific, high-risk, chronic lower extremity arterial disease populations. The guideline identifies these folks as being at particularly high risk of MACE, male, and death. Table 9 lists the risk factors, things like symptomatic arterial disease in more than one territory, polyvascular disease, chronic kidney disease including dialysis, diabetes mellitus, heart failure, and chronic limb-threatening ischemia.
Yeah, these are definitely the patients who keep us up at night. Table 9 references show some pretty sobering 5-year rates for amputation or death in these groups.
And given their substantially higher ischemic risk, the guidelines suggest that maybe a higher risk of bleeding might be more acceptable in these specific patients, simply because the potential absolute benefit from more intensive antithrombotic therapy could be greater. This thinking supports Recommendation 28, which is Class 2A, Level B. It says you should consider using aspirin 75-100 milligrams once daily in combination with Rivaroxaban 2.5 milligrams twice daily for chronic symptomatic lower extremity arterial disease patients who are not at high risk of bleeding, and especially those identified as being at higher ischemic risk, those criteria from Table 9.
So this is really applying the COMPASS trial findings to the patients who might stand to gain the most, but only if they're not already at high bleeding risk.
Exactly. It's all about linking the strategy to the individual patient's risk profile. Figure 2 in the guideline illustrates this decision pathway quite nicely. It shows how you assess both high bleeding risk based on criteria like those used in Compass Voyager exclusions, things like recent major bleeding, prior hemorrhagic stroke, severe liver disease, need for DIT or full-dose anticoagulation, the footnote describes these, and high ischemic risk based on that Table 9 criteria. If the patient has high bleeding risk, you generally avoid the combination. But if they have high ischemic risk and low bleeding risk, then the combination becomes a stronger consideration, Class 2A.
Okay, let's pause for a micro recap on chronic symptomatic lower extremity arterial disease. Single antiplatelet therapy is the foundation, Class 1, with clopidogrel being the recommended single agent, Class 1. Dual antiplatelet therapy is not recommended for secondary CV prevention due to bleeding risk outweighing MAC benefit, Class 3. Full-dose anticoagulation plus antiplatelet is also not recommended, Class 3. However, the combination of aspirin and low-dose Rivaroxaban 2.5 mg BID should be considered Class 2A in patients who are not at high risk of bleeding, especially those identified as being at higher ischemic risk based on specific clinical features like polyvascular disease, CKD, diabetes, heart failure, or CLTI.
That covers chronic management well. Let's now look at section 4.5.4, which addresses acute presentations of previously chronic lower extremity arterial disease. So these are patients with known PA who then develop acute limb ischemia, ALI.
The guideline points to the separate ESVS acute limb ischemia guidelines for the overall management of ALI, but it stresses here that these patients are at profoundly high risk of subsequent MACE and MALE. They cite data from trials like UC Light and Voyager, showing that having an ALI event significantly increased the hazard ratios for subsequent cardiovascular events, death, and major amputation.
This exceptionally high risk in patients with known PBA who then present with ALI provides the rationale for potentially more aggressive antithrombotic strategies right away, even without specific RCTs focused solely on this exact group.
What's the immediate management recommendation then for ALI?
Recommendation 29 is Class 1, Level C. It recommends immediate intravenous unfractionated heparin or low molecular weight heparin for patients presenting with acute limb ischemia. The goal is simply to reduce thrombus propagation while you figure out the next steps. This is a consensus-based recommendation for urgent anticoagulation.
And if you're planning to take them for expedited revascularization,
Recommendation 30, also Class 1, Level C, specifically recommends immediate intravenous unfractionated heparin for patients with acute limb ischemia who are planned for expedited revascularization. Again, consensus-based, aiming to limit clot extension and potentially improve procedural outcomes.
Okay, micro recap on acute presentations of chronic PA. Patients with known PA who develop ALI are extremely high risk for MELI-FA. Immediate forfeit unfractionated heparin or LMWH is recommended, Class 1, to prevent thrombus propagation. If expedited revascularization is planned, IV unfractionated heparin is recommended, Class 1.
Next up, Section 4.5.5, Periprocedural antithrombotics for lower extremity intervention. This covers therapy given right around the time of both endovascular and open surgery for lower extremity PAD.
Starting with intraprocedural anticoagulation, 4.5.5.1, using heparin during these procedures is pretty standard practice, isn't it?
It is, yes. Although the guideline does point out that high-quality randomized evidence specifically for its use during lower extremity arterial disease interventions is surprisingly limited. They reference a single RCT on open AAA repair comparing UFH versus no UFH, which did show better initial graft patency with heparin, but also predictably more bleeding events.
Despite that limited direct evidence in PAD, Recommendation 31 is Class 1, Level C. It recommends unfractionated heparin during endovascular or open arterial intervention for lower extremity arterial disease. This is a strong recommendation based largely on overwhelming consensus clinical practice and the general principle of preventing thrombosis during vessel manipulation or flow interruption.
And Recommendation 32, also Class 1, Level C, gets specific about timing. It recommends giving the unfractionated heparin before arterial clamping or flow restriction in open surgery or before crossing the lesion in endovascular intervention. This ensures you have anticoagulation coverage during those critical moments.
What are the typical dose and monitoring recommendations inter-procedure?
Recommendation 33, Class 1, Level C, provides the standard approach. It recommends an initial bolus of 5,100 international units per kilogram of unfractionated heparin with extra doses as needed to keep the activated clotting time, ACT, above a locally agreed target. The guideline notes that keeping the ACT above 250 seconds is a common target. This gives pretty specific guidance based on consensus.
Are there alternatives to heparin for intraprocedural anticoagulation?
Bivalirudin is mentioned as an option. Recommendation 34 is Class 2B, Level B. It says you may consider a bolus of bivalirudin, 0.75 milligiga chelation intraprocedurally, especially if heparin is contraindicated, maybe due to HIT risk. Bivalirudin is a direct thrombin inhibitor, short half-life, non-renal excretion, so it can be attractive in renal dysfunction. But it's a weaker Class 2B recommendation supported by Level B evidence, acknowledging it as an alternative, not the default like UFH.
Okay, moving to post-procedure antithrombotic therapy after endovascular arterial intervention, 4.5.5.2. We touched on this earlier, the increasing use of dual antiplatelet therapy, DAPT, after these procedures in PAID.
Yes. And the guideline notes this trend is partly because trials of newer devices, like drug-coated balloons or drug-eluting stents, often just mandated DAPT in their protocols, maybe without strong independent justification for PAD. And partly it's extrapolation from cardiology. However, the guideline's conclusion here is quite cautious. While recommending DAPT may be considered and is seen as reasonable in some patients, its routine or prolonged use should be limited because there's a real lack of specific safety and efficacy data for lower extremity arterial disease patients that's comparable to the strong evidence in coronaries. They really emphasize that after any period of DF, patients should go back to the standard recommendations for chronic symptomatic LEAs, section 4.5.2.
Recommendation 35 reflects this cautious stance, right? It's Class 2B, Level C.
Correct. It says you may consider a short course, minimum 1 month, maximum 6 months of dual antiplatelet therapy, aspirin 75 milligrams plus clopidogrel 75 milligrams, for patients undergoing endovascular intervention for lower extremity arterial disease who are not at high risk of bleeding. The stated goal is reducing secondary cardiovascular and major adverse limb events.
That Class 2B, Level C really highlights the uncertainty, doesn't it? Balancing a theoretical benefit against bleeding risk, based mainly on consensus. And the short duration is key.
Exactly. They also briefly mentioned the effect of silicizole after lower limb endo intervention, based on a meta-analysis suggesting it might help with patency, but it's not a primary recommendation.
Okay, now section 4.5.5.3. Endovascular intervention post-procedure, but now considering anticoagulants and combination therapy. The combination of aspirin, 100 milligrams daily, and Rivaroxaban, 2.5 milligrams twice daily, comes up again, this time based on the Voyager PAD trial. Voyager studied this combination specifically in patients undergoing lower limb revascularization, both endovascular and surgical, for symptomatic PD.
That's right. It had specific exclusion criteria for high bleeding risk, similar but slightly different from COMPASS, again detailed in the footnotes of figures 2 and 3, which resulted in a trial population with a relatively low baseline bleeding risk compared to many real-world patients. The main finding of Voyager was that the combination of aspirin plus low-dose Rivaroxaban significantly improved the primary composite efficacy outcome, which was MAE plus MALE, compared to aspirin alone over a median follow-up of about 28 months.
Did Voyager give us specific insights into the endovascular subgroup versus the surgical subgroup?
Yes, it did subgroup analyses by the type of revascularization. Interestingly, the positive effect on the primary composite outcome reached statistical significance in the surgical subgroup, but technically did not in the endovascular subgroup. However, and this is important, the guideline notes, there was no statistically significant difference in the treatment effect between the surgical and endovascular subgroups. So you can't definitively say it worked in one but not the other based on that analysis alone, even though the signal looked stronger in the surgical group.
Voyager also had a lot of patients, about half, who were also on clopidogrel, especially in the endovascular group. Did they look at triple therapy?
They did a non-powered subgroup analysis looking at adding clopidogrel. It found that adding clopidogrel to the aspirin plus Rivaroxaban combination did not seem to improve efficacy, but did significantly increase IST criteria major bleeding, particularly when used for more than 30 days. That's a really critical finding about the risk of triple therapy in this setting.
So, based on Voyager, what's the recommendation for using aspirin plus low-dose Rivaroxaban after endovascular intervention?
Recommendation 36 is Class 2A, Level B. It says you should consider aspirin 75-100 milligrams once daily, combined with Rivaroxaban 2.5 milligrams twice daily, for patients undergoing endovascular intervention for lower extremity arterial disease who are not at high risk of bleeding. The goal is stated as reducing secondary cardiovascular and major adverse limb events. This is a Class 2A recommendation based on Level B evidence from Voyager, acknowledging the overall trial benefit while implicitly noting those subgroup nuances.
And based on that finding about triple therapy in Voyager.
Recommendation 37 is Class 3, Level C, and it's strong. It does not recommend adding clopidogrel 75 milligrams to the combination of aspirin plus rivaroxaban for longer than 30 days, even in exceptional circumstances, for patients undergoing endovascular intervention. The rationale, based on that Voyager subgroup data, is that the increased bleeding risk is very likely to outweigh any potential benefit from prolonged triple therapy.
Figure 3 summarizes these recommendations for endovascular intervention, intra-procedure, UFH Class 1, or bivalirudin Class 2B. Post-procedure, for low bleeding risk patients. Two options, either a short course of APTT, aspirin plus clopidogrel 1 to 6 months, Class 2B, or aspirin plus low-dose rivaroxaban, indefinite, Class 2A. It clearly shows the Class 3 against adding clopidogrel for 30 days to the aspirin plus rivaroxaban combo. And it covers what to do if patients are already on full-dose anticoagulation.
Okay, let's shift now to open arterial surgery antithrombotic therapy, 4.5.5.4. After open bypass surgery, antiplatelet therapy is common, but the guideline notes a lack of specific trials comparing single antiplatelet therapy versus placebo or no treatment right after bypass in PAD.
Despite that lack of specific comparative trials, Recommendation 38, which seems to cover both single antiplatelet and combination therapy considerations in the source, states that using single antiplatelet therapy may be considered. That's Class 2B, Level C. This is for patients undergoing infranguinal endarterectomy or bypass, vein or prosthetic, who are not at high risk of bleeding.
Right. It's based on consensus and extrapolation, recognizing their underlying atherosclerosis and the potential for local thrombosis after surgery. It's a weaker recommendation reflecting the lack of direct evidence comparing it to nothing in this specific setting.
Now, Section 4.5.5.5, open arterial surgery, looking at anticoagulants and combination therapy. The use of anticoagulation after open bypass has been studied, most famously with vitamin K antagonists in the BOA trial. The BOA trial compared warfarin versus aspirin after infranguinal bypass.
Yes. It compared warfarin, targeting a quite high INR range of 3.0-4.5 against aspirin. The results were mixed. Warfarin did show a reduction in graft occlusion compared to aspirin, which is good. But it also led to a significantly increased risk of major bleeding, hazard ratio 1.96. The time and therapeutic range for warfarin was pretty low in BOA, around 50%, which likely didn't help either outcome. And a subgroup analysis showed major bleeding itself was linked to major ischemic complications. It's a real double-edged sword.
So while warfarin might improve patency, the bleeding risk at that high INR target was a major problem.
It certainly was. So acknowledging the BOA findings, the patency benefit, but also the high bleeding rate, the guidelines writing group reached a pragmatic consensus recommendation. If a vitamin K antagonist is used after bypass, they suggest a lower INR target of 2.0-3.0, aiming for 2.5. They explicitly state this lower target is based on pragmatism rather than strong evidence showing it's better or safer than antiplatelets in this specific range after bypass.
How does the Voyager trial's data in the surgical subgroup fit into this post-bypass picture?
As we mentioned for endo, Voyager had a surgical subgroup undergoing open bypass. In this subgroup, the combination of aspirin plus low-dose rivaroxaban showed a positive effect on the primary composite efficacy outcome, MCE plus male reduction hazard ratio 0.79 compared to aspirin alone. And critically, major bleeding was not increased in this surgical subgroup, hazard ratio 1.02, with the combination. This was quite different from the finding in the endovascular subgroup or the overall trial bleeding result.
That difference in bleeding outcomes between the surgical and endovascular subgroups in Voyager is really interesting.
It is, and this led the guideline committee to give a higher class recommendation for aspirin plus low-dose rivaroxaban than for vitamin K antagonists after bypass. Even though the Voyager subgroup analyses weren't powered for definitive conclusions and didn't stratify by graft type, vein versus prosthetic.
So, based on that Voyager surgical subgroup data suggesting benefit without excess bleeding, Recommendation 38, the second aspect it covers, is Class 2A, Level B. It should be considered to use aspirin 75-100 milligrams once daily in combination with rivaroxaban 2.5 milligrams twice daily for patients undergoing infranguinal endarterectomy or bypass, vein or prosthetic, for lower extremity arterial disease who are not at high risk of bleeding. This recommendation is directly tied to those Voyager surgical subgroup findings.
And mirroring the endovascular section again, Recommendation 39, Class 3, Level C, does not recommend adding clopidogrel 75 milligrams to the aspirin plus rivaroxaban combination for longer than 30 days, even in exceptional circumstances after infranguinal bypass surgery. Same rationale. Voyager subgroup data suggests increased bleeding without clear benefit from prolonged triple therapy.
Now, back to vitamin K antagonists post-bypass. Recommendation 40 is Class 2B, Level C. It says you may consider a vitamin K antagonist targeting that lower INR of 2.0, 3.0, aiming for 2.5. Specifically for patients undergoing infranguinal endarterectomy or bypass using a prosthetic conduit who are not at high risk of bleeding.
Right. This is a Class 2B recommendation based on consensus, Level C. It acknowledges the BOA trial's patency benefit but high bleeding risk at the higher INR and pragmatically suggests the lower INR target, specifically for prosthetic grafts where the thrombosis risk is generally thought to be higher than with vein grafts.
Figure 4 visually summarizes the recommendations for lower limb bypass. It branches on bleeding risk, high versus low, footnote defines high. For low bleeding risk, it branches by graft type, vein versus prosthetic. For vein, options are single antiplatelet, Class 2B, or aspirin plus Rivaroxaban, Class 2A. For prosthetic, options are single antiplatelet, Class 2B, aspirin plus Rivaroxaban, Class 2A, or VKA targeting 2.0, 3.0, Class 2B. It also shows the Class 3 limitation on prolonged triple therapy.
That was a really thorough journey through atherosclerotic, lower extremity arterial disease management, from medical therapy all the way to peri-procedural considerations.
Indeed. That racks up the major atherosclerotic arterial sections. Let's take a mega recap of section 4.1 through 4.5.5, covering arterial disease management from carotid down to lower extremity interventions. For asymptomatic carotid, single antiplatelet, Class 1, DAPT anticoagulation not recommended, Class 3. For symptomatic carotid, minor stroke high risk TIA, DAPT for 21 days, Class 1, then single. Peri-CAS antiplatelets recommended, Class 1. Post-CS, DAPT for 4 weeks and single clopidogrel, Class 1. Long-term DOBT not recommended, Class 3. For upper limb and renal mesenteric, limited data, single antiplatelet considered for symptomatic, Class 2A. Short DIBT considered post-renal mesenteric reverse, Class 2A. For chronic symptomatic LAAs, single antiplatelet, clopidogrel preferred, strongly recommended, Class 1. DIBT for CV prevention not recommended, Class 3. Aspirin plus low-dose Rivaroxaban should be considered, Class 2A, in low bleeding high ischemic risk patients. For ALOI, immediate IV heparin recommended, Class 1. Peri-lower limb intervention, UFH recommended intra-procedure, Class 1. Post-end, short DAPT may be considered, Class 2B. Aspirin plus low-dose Rivaroxaban should be considered, Class 2A, in low bleeding risk patients based on Voyager. Prolonged triple therapy not recommended, Class 3. Post-open bypass. Single antiplatelet may be considered, Class 2B. Aspirin plus low-dose Rivaroxaban should be considered, Class 2A, based on Voyager surgical data. VKA INR 2.0, 3.0 may be considered, Class 2B for prosthetic grafts. Prolonged triple therapy not recommended, Class 3.
Phew, that was a lot. Okay, now let's move into section 4.6. Non-atherosclerotic peripheral artery diseases.
Right. This is a really diverse group of conditions affecting arteries, but not caused by typical atherosclerosis. And the guideline notes that, unfortunately, specific high-quality evidence for antithrombotics in most of these is, well, lacking. So recommendations often rely on consensus or extrapolation from the atherosclerosis guidelines.
Yeah, they mention conditions like Adamantiadi-Besset's disease, which is a systemic vasculitis affecting arteries and veins. Specific antithrombotic evidence there is limited.
Also, Berger's disease, thromboangiitis obliterans.
Yes, Berger's, that non-atherosclerotic inflammatory disease of small and medium vessels, mostly in smokers. The guideline references a Cochrane analysis suggesting intravenous Elaprost might be better than aspirin for rest pain and ulcers, but it has side effects. For antithrombotic therapy itself, though, the guideline notes that because of the lack of specific evidence in Berger's, the recommendations we just covered for atherosclerotic disease in section 4.5 might still be considered relevant, kind of by default.
What about large vessel vasculitis, like Takayasu's or giant cell arteritis, affecting the aorta and big branches?
In those conditions, the main treatment is usually immunosuppression to cool down the inflammation. But antithrombotics still play a role in preventing secondary clots, especially if patients also have conventional cardiovascular risk factors or documented arterial lesions from the vasculitis itself. Recommendation 41 is Class 2B, Level C. It says you may consider single antiplatelet therapy for patients with large vessel vasculitis, particularly if they have those conventional risk factors or documented lesions. It's based on consensus and extrapolation.
They also discuss virus-related vascular disease, specifically HIV and COVID-19.
Right. HIV is known to increase the risk of both arterial and venous thrombosis, especially combined with traditional risk factors or infections. But similar story, there's a lack of specific evidence for antithrombotics tailored just for HIV-related vasculopathy.
So recommendation 42, class 2B level C, says you may consider single antiplatelet therapy for patients with HIV-associated vasculopathy. Again, particularly if they have additional conventional risk factors or documented lesions, based on consensus.
And COVID-19, which was such a huge focus for thrombosis during the pandemic.
Yeah, the guideline acknowledges the potential impacts of COVID-19 on thrombotic risk and management. They note multiple RCTs were ongoing when they wrote it. They mention one Iranian RCT that didn't show a benefit of intermediate versus standard dose prophylactic anticoagulation in ICU patients with COVID. They also note reports of heparin resistance, but the incidence was unclear. Crucially, though, based on the evidence available at the time the guideline was written, they concluded there were no data sufficient to support changing the guideline recommendations for any specific COVID-related indication at that point. They did emphasize the evidence was evolving rapidly.
So as of this guideline, you'd basically apply the standard recommendations for the underlying vascular issue, irrespective of a COVID diagnosis, unless specific new, strong evidence had emerged since then.
That was the position based on the evidence they could review at the time, yes.
Okay, quick micro recap on non-atherosclerotic arterial diseases. For conditions like Buerger's, recommendations for atherosclerotic disease might apply due to lack of specific data. Single antiplatelet may be considered, class 2B level C, for large vessel vasculitis and HIV-associated vasculopathy, especially with CV risk factors or lesions. For COVID-19-related thrombosis, standard guidelines should be followed, acknowledging evolving evidence as of guideline publication.
Moving on to section 4.7, arterial embolism. This is about acute arterial occlusion from an embolus, often coming from the heart, like an AFib, or sometimes from proximal plaques.
And in the initial management of acute embolic ischemia, anticoagulation is absolutely key, isn't it?
Yes. The guideline recommends getting therapeutic anticoagulation on board rapidly, typically with intravenous unfractionated heparin, cross-referencing the ALI recommendations in 4.5.4. The goal is twofold: stop the thrombus extending locally and, critically, prevent recurrent emboli from the source, which is often still active.
How should the IV heparin be monitored?
Activated partial thromboplastin time, APTT NOMAS, are recommended to guide dosing, with anti-Xi level monitoring noted as an alternative. Standard heparin infusion monitoring.
And what's the plan after intervention, like an embolectomy?
Post-revascularization, the therapy needs to transition to long-term oral anticoagulation. This often involves bridging with LMWH or fondaparinux. The choice of the long-term oral agent warfarin or a DOAC really depends on the underlying cause of the embolism, like atrial fibrillation or a mechanical valve.
The guideline mentions a couple of small case series here.
Yeah, they note a single-center series suggesting long-term oral anticoagulation reduced recurrent ALI and amputation after an embolic event. Another small one looked at outcomes after thromboembolectomy based on whether patients had AFib, highlighting the importance of the source.
So based on that high risk of recurrence from the embolic source, what's the main recommendation for long-term management?
Recommendation 43 is class 1, level C. It recommends long-term anticoagulation for patients who've had an acute embolic arterial ischemia, unless there's a clear high risk of bleeding that makes it unsafe. This is a strong recommendation based on consensus and clinical experience, recognizing you have to treat the underlying source to prevent it happening again.
Got it. Micro recap on arterial embolism. Immediate 4V unfractionated heparin is recommended, class 1, to prevent extension recurrence. Long-term anticoagulation is recommended, class 1, to prevent recurrence unless high bleeding risk contraindicates it, with the agent chosen based on the embolic source.
Okay, moving to section 4.8, aneurysmal disease.
Atherosclerotic aneurysms, like abdominal aortic aneurysm, FREEL-A, are closely tied to generalized atherosclerosis and cardiovascular risk factors.
And given that strong link to systemic atherosclerosis, Recommendation 44, Class 2B, Level C, suggests you may consider single antiplatelet therapy, specifically aspirin 75, 100 milligrams daily for patients with small abdominal aortic aneurysms. The main goal isn't really to affect the aneurysm growth, but to reduce the overall burden of cardiovascular events in this high-risk population. They note this is Class 2B based on consensus and extrapolation, and might differ from some older guidelines.
What about after an aneurysm is repaired, either open or endovascularly, AVAR?
Recommendation 45 is Class 1, Level C. It recommends aspirin 7,500 milligrams daily indefinitely for patients undergoing open or endovascular repair of a AAA, provided they don't already have a separate indication for full-dose anticoagulation. This is a strong recommendation based on consensus, recognizing their ongoing systemic risk and the presence of graft material or surgical repair.
The guideline also mentions that tricky scenario of finding isolated thrombus just sitting within an aneurysm sac or even within a stent graft.
Yes, and notes that there's a significant lack of high-quality evidence, specifically to guide how to manage that. Clinical practice varies quite a bit, but there isn't a consensus evidence-based recommendation provided here.
Okay, micro recap on aneurysmal disease. Single antiplatelet may be considered Class 2B Level C for small AAA for CV risk reduction. Lifelong aspirin is recommended, Class 1 Level C, after AAA repair if no other full-dose anticoagulation is needed. Management of isolated thrombus in an aneurysm or stent graft lacks specific guideline recommendations.
Let's move to section 4.9, arteriovenous fistula and graft for hemodialysis access.
Right, in this population, often patients with CKD, which we'll get to more later, antithrombotics are considered to try and improve maturation and long-term patency of their dialysis access.
The guideline first looks at using intraoperative unfractionated heparin during the creation of these accesses. They discuss a meta-analysis of 4 RCTs. This found that while intra-op systemic heparin did seem to increase initial patency for arteriovenous fistulas, AVF, it led to a much bigger increase in bleeding events. And for arteriovenous grafts, AVG, it showed no effect on patency at all, initial or late, and it didn't help late patency for AVS either.
So the bleeding risk from heparin during creation seemed to outweigh any potential benefit, especially for grafts.
Exactly, which led to a strong recommendation against it.
Hmm.
Recommendation 51 is Class 3, Level A. It does not recommend systemic unfractionated heparin during arteriovenous fistula or graft formation. That's a Class 3 based on Level A evidence from the meta-analysis, clearly pointing to harm, bleeding without overall benefit.
What about using antithrombotics after the AVF or AVG is created? The guideline looks at meta-analyses and a large RCT here.
Yes, and notes the meta-analyses has some differences. The guideline focuses on a large, higher-quality RCT of nearly 900 patients that compared clopidogrel 75 milligrams daily versus placebo after AVF formation. This trial found a significant reduction in early thrombosis with clopidogrel. But, and this is a key point, it found no improvement in the number of fistulas that were actually usable for dialysis later on.
That's a really important distinction. Stopping a clot doesn't always mean you get a working fistula.
Right. The guideline notes that when this big trial was pooled with another smaller one in meta-analysis, the effect on early thrombosis became non-significant. But they still consider the larger trial's finding of reduced early thrombosis as the dominant evidence supporting a potential benefit. Based on this and another meta-analysis suggesting antiplatelet monotherapy for up to 6 months after AVF formation was favorable without increasing bleeding, Recommendation 52, Class 2A, Level B, says you should consider single antiplatelet therapy, specifically clopidogrel 75 milligrams, for up to 6 months after arteriovenous fistula formation, with the stated aim of improving patency.
So a Class 2A recommendation, Level B evidence, mainly from that large clopidogrel trial, but with that nuance about functional access versus just thrombosis.
Correct. And Recommendation 53, Class 2B, Level C, says you may consider single antiplatelet therapy with aspirin 75 or 100 milligrams daily as an alternative if clopidogrel is contraindicated. That's a weaker recommendation based on consensus.
What about managing things around angioplasty for stenotic lesions that develop later in AVFs?
The guideline mentions common practice involves a single dose of intraprocedural heparin and continuing antiplatelets, but notes there's really a lack of specific evidence to firmly support that particular approach.
And for AVGs, the grafts, how does the evidence look there?
It's less robust than for AVS. An older meta-analysis of low-quality RCTs showed no benefit for early primary patency with antiplatelets versus placebo. However, more recent meta-analysis that included a large national database case series did suggest a benefit for reducing early thrombosis, specifically for prosthetic grafts.
So, given that somewhat conflicting and lower quality evidence for grafts, Recommendation 54 is Class 2B, Level C. It says you may consider single antiplatelet therapy for up to 6 months after formation of a non-autologous arteriovenous graft to improve graft patency.
Exactly. It's a Class 2B recommendation based on consensus and that weaker evidence base, acknowledging more uncertainty compared to the AVF recommendations.
Okay, micro recap on AVF SAVGs. Systemic intraoperative heparin is not recommended, Class 3 Level A, due to bleeding risk. After AVF creation, single antiplatelet, clopidogrel preferred, should be considered for up to 6 months, Class 2A2B, to improve patency based on trial data. After AVG creation, single antiplatelet may be considered for up to 6 months, class 2B, based on weaker evidence.
All right, that was a deep dive into various specific arterial conditions. Now let's turn to section 4.11, specific patient populations that often require, well, nuanced consideration when it comes to antithrombotics.
Starting with chronic kidney disease, 4.1, 1.1. This is always a tough group, isn't it? Because patients with CKD, especially advanced stages or dialysis, have historically been left out or underrepresented in the big cardiovascular trials, which makes it hard to apply the findings directly.
Absolutely, and their risk profile is so complex, they're at high risk of both thrombotic events and bleeding events. It's a real challenge. Studies of aspirin monotherapy for primary CV prevention in CKD generally haven't shown benefit and have shown increased bleeding. The benefit of clopidogrel in CKD, based on trials like CEADU, is also uncertain.
And vitamin K antagonists like warfarin, they also present specific challenges in CKD, don't they?
They definitely do. You worry about altered drug metabolism, changes in protein binding, and certainly an increased risk of bleeding, especially at higher INRs. And then there's that rare but serious risk of warfarin-induced calciphylaxis in patients with severe CKD or on dialysis. It just requires extremely careful dosing and monitoring.
How do the direct oral anticoagulants, the DOACs, fit in for CKD patients needing anticoagulation?
Well, DOACs are generally preferred over VKAs in many non-CKD settings because they're more predictable and have lower bleeding risk. But their use in advanced CKD gets complicated because different DOACs have different amounts of renal excretion. They're generally used down to certain eGFR cutoffs based on their licenses and trial data. But for severe CKD, say eGFR 30, or for dialysis patients, the evidence is much weaker. And VKAs are often still used in those situations, despite all their challenges.
This complexity is reflected in recommendation 55, which is class 2B level C.
Right. It says you may consider direct oral anticoagulants for patients with CKD stage 3 or 4, that's eGFR down to 30, who need anticoagulation for a peripheral artery disease indication. For patients with eGFR less than 30, vitamin K antagonists may be considered. But the guideline strongly stresses, and this is key, that the risk balance in CKD is complex and decisions must be strictly individualized. You have to consider the specific patient, their exact eGFR, their reason for anticoagulation, and their bleeding risk.
For preventing recurrent VTE in CKD patients, the recommendation for DOACs seems slightly stronger.
Yes. Recommendation 56 is Class 2A, Level B. It says you should consider direct oral anticoagulants for patients with CKD stage 3 or 4, eGFR of 30, who need anticoagulation for recurrent venous thromboembolism prevention. This is based on Level B evidence suggesting reasonable efficacy and safety down to that eGFR cutoff specifically for VTE.
What about using heparin in CKD?
Unfractionated heparin is often preferred in acute settings, even with CKD, mainly because of its short half-life and the fact that you can reverse it quickly with protamine if needed. Expert opinion suggests considering a reduced initial standard dose, maybe by about a third, in severe CKD and then adjusting carefully based on APTT monitoring. Low molecular weight heparins, on the other hand, definitely accumulate in CKD because they're renally excreted. Meta-analyses have shown increased bleeding risk with standard dose LMWH in severe CKD compared to dose-adjusted LMWH or compared to patients without CKD, especially with agents like enoxaparin. One meta-analysis even found increased bleeding risk associated with CKD, defined as eGFR below 60.
So dose adjustment and maybe monitoring factor Z levels become really important for LMWH and CKD.
It's exactly. Recommendation 57, Class 2A, Level C, says you should consider regular monitoring of renal function and dose adjustment for patients with CKD stage 3 or 4, specifically eGFR 15 to 59, who require anticoagulation with low molecular weight heparin. The aim is clearly to reduce the risk of accumulation and subsequent bleeding.
Okay, micro recap on CKD. Managing antithrombotics is complex, needs strict individualization. For PADI indications needing anticoagulation, DOACs may be considered for eGFR 30+, while VKAs may be considered for eGFR 30 class 2B level C. For recurrent VTE prevention, DOACs should be considered for eGFR 30+, class 2A level B. For heparin, UFH often preferred acutely. Careful monitoring and dose adjustment should be considered for LMWH in CKD stage 34, class 2A level C.
Next, Section 4.11.2 addresses cancer-associated arterial thromboembolic events. It's well known that cancer patients have a significantly increased risk of arterial clots compared to the general population. The risk is highest around diagnosis.
And certain cancers carry higher risk, like hematological, lung, and GI cancers.
Right. But despite this clear association, The guideline notes a striking lack of randomized controlled trial data, specifically looking at antithrombotic therapy for preventing or treating arterial thromboembolic events in cancer patients. Practice is also extrapolated from the much larger evidence base for cancer-associated venous thromboembolism. Because of this specific lack of data for arterial events in cancer, the guideline explicitly states that no specific recommendations can be made in this document regarding antithrombotic therapy for cancer-associated arterial thromboembolic events.
Okay, moving on to section 4.11.3, patients with pre-existing indications for antithrombotics. This is such a common scenario of the patient with PAD who also needs anticoagulation for AFib, or maybe needs DAPT for a recent coronary stent.
Yeah, very common. The guideline highlights that PAD patients in registries like REACH were actually at higher risk of future CV events than CAD patients alone, and those with a pre-existing need for anticoagulation were at particularly high risk. Patients with polyvascular disease, symptomatic disease, and more than one bed are generally at the highest risk overall. There's overlaps, but also differences between CAD and PAD risk profiles, and a lack of good comparisons for optimal antithrombotic strategies when indications collide.
The WAVY trial is critical here again, looking at the safety of combining antiplatelets with full-dose anticoagulation.
Yes, as we've discussed, WAVE randomized patients with arterial disease to full-dose VKA plus aspirin versus aspirin alone. The finding of no benefit but a threefold increase in life-threatening bleeding with the combination is really foundational when considering patients who need full-dose anticoagulation for a separate reason.
Which leads to very strong recommendations against routinely combining therapies. Recommendation 58 is Class 3, Level B.
Right. It does not recommend the routine addition of antiplatelet therapy to full-dose anticoagulation for patients who have chronic peripheral artery disease and a separate cardiac or vascular indication requiring full-dose anticoagulation.
And Recommendation 59, also Class 3, Level B, goes even further.
Yes, it recommends stopping antiplatelet therapy if a patient is already taking it for their PED and then develops another condition, like new AFib, that requires full-dose anticoagulation for that other reason. This is directly based on the significant bleeding harm shown in WAVE with these combinations for general atherosclerosis management.
So generally, if your PA patient needs full-dose anticoagulation for something else, you should stop their aspirin or clopidogrel for their PC.
That is the strong recommendation based on the evidence. However, they do acknowledge a very limited exception. Recommendation 60 is Class 2B, Level C. It says you may exceptionally consider adding single antiplatelet therapy for a maximum of 3 months for patients who are already on full-dose anticoagulation and are undergoing endovascular intervention for PBAY. The idea is maybe to reduce periprocedural or early post-procedural ischemic events.
The words exceptionally and maximum of 3 months seem really important there.
Absolutely. It's a weaker Class 2B recommendation based on consensus, acknowledging a theoretical short-term benefit around a procedure, but heavily constrained by that strong WAVE evidence showing the bleeding risk of longer-term combination therapy.
The guideline also notes that patients already on anticoagulants who then have a TIA or stroke and might need carotid surgery should then follow the specific short-term DAPT recommendations from Section 4.1 for symptomatic carotid disease, obviously managing the combination risks very carefully.
Section 4.11.4 addresses thrombophilia. These are inherited or acquired conditions predisposing to thrombosis. While we usually think of them with VTE, some are linked, though less strongly, to arterial events. Antiphospholipid syndrome, APS, is noted as having a documented increased risk of arterial clots, while others, like protein CS deficiency, factor V Leiden, prothrombin gene mutation, are less clearly associated. Table 10 lists examples.
Given thrombophilia is a rare cause of arterial events compared to atherosclerosis, is routine testing recommended for patients presenting with arterial thrombosis?
No. Recommendation 61 is Class 3, Level C. It does not recommend routine investigation for thrombophilia in patients with arterial thromboembolism. This is based on how rarely it's the primary cause in this setting and the lack of clear impact on antithrombotic management compared to just treating the atherosclerosis. The guideline stresses that if you do suspect thrombophilia based on the clinical picture, maybe arterial clots in unusual places, young patient, no risk factors decisions about testing and therapy should only be made in consultation with a specialist hematologist.
They discuss the controversy around long-term antithrombotic therapy once a thrombophilia is diagnosed after an arterial event, noting the lack of data for many specific conditions.
Yes, they reference a Cochrane review on antiphospholipid syndrome comparing different strategies. While mostly based on VTE patients, it suggested that in the overall group, DOACs might increase stroke risk compared to vitamin K antagonists, with no overall improvement in thromboembolic events. However, they do note that for low-risk APS, single or double antibody positive, no prior arterial small vessel clots, DOACs like apixaban or dabigatran may be an option, but this needs more evidence. For any other thrombophilia, the guideline basically says there's not enough data to make recommendations on long-term antithrombotics after an arterial event.
So, bottom line for thrombophilia and arterial events, don't routinely test. If suspected or confirmed, involve hematology. Be cautious with DOACs and high-risk APS after thrombosis.
That sums it up well.
Okay, let's take a mega recap of sections 4.6 through 4.11 covering specific arterial conditions and populations. We discussed non-atherosclerotic arterial diseases where evidence is limited, leading to consensus recommendations like considering single antiplatelets in large vessel vasculitis or HIV vasculopathy, class 2B. For arterial embolism, immediate IV heparin and long-term anticoagulation unless high bleeding risk are strongly recommended, class 1, due to recurrence risk. For aneurysmal disease, aspirin may be considered for small AAA, class 2B, for CV risk, and is recommended lifelong post-repair, class 1, if no other AC needed. Isolated thrombus lacks guidance. In AVF-AVG creation, intra-op heparin not recommended, class 3. Post-AVF, single antiplatelet, clopidogrel preferred, should be considered up to 6 months, class 2A-2B. Post-AVG, single antiplatelet may be considered, class 2B. We covered complex populations, CKD, highly individualized AC based on EGFR LMWH monitoring, considered. Cancer-associated arterial events, no specific guideline recommendations due to lack of data. Patients on pre-existing full-dose AC, generally stop antiplatelets for chronic PA, class 3. Limited short-term exception post-endo, class 2B, and thrombophilia, routine testing for arterial events not recommended, class 3, needs specialist input, caution with DOACs and high-risk APS.
That concludes the very extensive Section 4 on arterial disease. Now let's pivot entirely and move into Section 5. Antithrombotics for patients with venous disease.
After that huge dive into the arterial side, it's crucial to acknowledge the equally important role of antithrombotics in managing venous conditions, everything from preventing clots to treating DVT and superficial issues.
Absolutely. Let's begin with Section 5.1, prophylaxis for venous thromboembolism.
Before any procedure, VTE risk has to be considered, right?
Yes. And Recommendation 62, Class 1, Level C, makes this fundamental point. It recommends an individually personalized venous thromboembolism risk assessment for all patients undergoing any vascular procedure. It's a strong recommendation based on consensus, acknowledging that assessing individual risks is the essential first step to decide if prophylaxis is actually needed.
Okay, moving to Section 5.2, deep vein thrombosis, or DVT. The guideline defines the treatment phases, which helps structure things. There's the acute phase, up to 10 days, the principal treatment phase, the first 3 months, and the extended treatment phase, beyond 3 months, which varies in trials, but here defined as another 3 months or more after the principal phase. And proximal DVT means popliteal vein or higher.
Section 5.2.1 focuses on anticoagulation for that principal treatment phase, those critical first 3 months.
Historically, it was warfarin after initial heparin, but the landscape has really shifted with the direct oral anticoagulants, the DOACs.
Massively shifted. The guideline highlights the big advantages of DOACs over vitamin K antagonists for treating DVT. Things like simpler dosing, fixed doses, no routine monitoring, rapid onset, fewer drug and food interactions, non-inferior efficacy in preventing recurrent VTE, and crucially, better safety, less major bleeding overall, and significantly less intracranial hemorrhage compared to VKAs. LMWHs are still used, of course, particularly where DOACs might be contraindicated, like severe renal impairment, certain drug interactions, or maybe high-risk APS, or for initial bridging in some protocols.
This comparison leads to a strong preference for DOACs for most DVT patients now.
Yes, definitely. Recommendation 63 is Class 1, Level A, and very clear. It recommends a 3-month course of a full-dose direct oral anticoagulant rather than a vitamin K antagonist for most patients with proximal deep vein thrombosis. The goal is reducing recurrent thromboembolic events. This is a robust Class 1 recommendation based on Level A evidence from those pivotal Phase 3 DOAC trials Amplify with apixaban, Einstein with Rivaroxaban, Hokusai with edoxaban, and Rivaroxaban with dabigatran. Table 11 in the guideline nicely summarizes the key findings, showing non-inferior efficacy and significantly reduced major bleeding with DOACs versus VKAs.
The guideline also provides those useful tables, Table 6, comparing characteristics of specific DOAs, VKAs, LMWHs, and UFH, things like bioavailability, onset, half-life, renal excretion, which are really important for clinical use, especially in CKD. And it reminds us about monitoring APTT for UFH and risks like HIT.
An important caveat to the DOAC preference for DVT is for patients with DVT and antiphospholipid syndrome. The guideline specifically says DOACs are not recommended for those who are triple positive for APS antibodies or have a history of arterial or small vessel thrombosis. In these high-risk APS patients, a vitamin K antagonist should be used instead, often targeting a higher INR like 2.5, 3.5. However, for patients with low-risk APS, single or double positive, no prior arterial small vessel clots, DOACs like apixaban or dabigatran may be appropriate, but they note this needs more evidence.
Okay, micro recap on DVT principal phase. Individualized VTE risk assessment recommended pre-procedure, class 1. For proximal DVT, a 3-month course of a full-dose DOAC is recommended over VKA for most patients, class 1 level A, based on better safety, similar efficacy. Exceptions include high-risk APS where VKAs are preferred.
Section 5.2.2 covers extended anticoagulation therapy beyond that initial 3-month principal phase. This decision usually comes up for patients with an unprovoked DVT, no clear temporary risk factor, or those with persistent risk factors as they're at higher risk of recurrence if you stop.
If extended anticoagulation is needed, which agent is preferred, long-term DOAC or VKA?
Recommendation 64 is Class 2A Level B. It says you should consider full-dosed direct oral anticoagulants rather than vitamin K antagonists for patients with a proximal DVT needing extended anticoagulation after the first 3 months. This reflects the continued better safety profile of DOACs for long-term use compared to VKAs based on Level B evidence, making them the preferred option for many needing prolonged therapy.
What about using aspirin for extended prevention after a DVT? Can patients just switch to aspirin long-term?
No. Recommendation 65 is Class 3 Level A and very clear. It is not recommended to use aspirin for extended antithrombotic therapy in patients with unprovoked DVT who are eligible for and can tolerate full-dose anticoagulants. This is based on Level A evidence showing aspirin is just much less effective than anticoagulants at preventing recurrent VTE in this setting. While aspirin might be slightly better than placebo after stopping anticoagulation based on Warfaspire, its efficacy pales in comparison to continued full-dose anticoagulation.
The decision about how long to extend anticoagulation is always tricky, balancing recurrence risk versus bleeding risk.
It really is. The guideline discusses this, noting decisions depend on balancing those risks. They mention various risk scores, like ACCP recurrence criteria, VTE bleed, right, but also point out many lack robust validations specifically for venous indications. They also note that generally, patients with venous indications seem to be at lower major bleeding risk from anticoagulation compared to patients with arterial indications, which is a factor in that risk-benefit calculation for going long-term.
Let's move to section 5.3, superficial vein thrombosis or SVT.
Right, SVT, sometimes called phlebitis. It's not always as benign as it sounds. There's a real risk of it extending into the deep veins, causing DVT or even PE. The risk is higher if the SVT is near the junction with the deep veins, SFJ or SPJ, if it's clinically expensive, or in patients with risk factors like cancer or prior VTE. Studies show maybe 20–30% of patients diagnosed with SVT already have a silent DVT or PE.
What are the recommended treatments for SVT then?
The guideline reviews evidence for fondaparinux, LMWHs, and NSAIDs, though NSAIDs are mainly for symptoms. They cite findings from trials in Table 12 Stenox, Vesalio, Callisto, Steflux, Surprise. The Callisto trial stands out. It showed fondaparinux cut a composite outcome, death, DVT, PE, by 85% compared to placebo in SVT patients. And an observational study, Insights SVT, also suggested fondaparinux was better than LMWH for the composite outcome.
These findings lead to specific recommendations based on the SVT location relative to the deep junction. For SVT, extending 3 centimeters or more from the junction.
Recommendation 68 is Class 1, Level B, a strong recommendation. It recommends prophylactic dose fondaparinux, specifically 2.5 milligram daily subcutaneous, or prophylactic low molecular weight heparin for these patients. This is mainly based on that Level B evidence from Callisto for fondaparinux, plus other data for LMWH.
What if fondaparinux or LMWH isn't an option?
Recommendation 69 is Class 2B, Level C. It says you may consider a prophylactic dose, direct oral anticoagulant, specifically Rivaroxaban 10 milligrams once daily, for patients with SVT extending 3 centimeters or more from the junction. This is a weaker recommendation based on trials like Surprise, positioning it as an alternative.
And what's the recommended duration for treating SVT that's 3 centimeters or more from the junction?
Recommendation 70 is Class 1, Level A, giving a specific duration based on good evidence. It recommends 45 days of prophylactic antithrombotic therapy for these patients. That 45-day duration comes largely from Callisto.
Should therapy ever go beyond 45 days for SVT?
Recommendation 71, Class 2B, Level C, says you may consider extending anticoagulation beyond 45 days for patients with SVT near a junction, particularly if they have specific high-risk features. These include things like extensive thrombosis, 5 centimeters long, involvement of an axial vein, GSVS-SV, multiple veins involved, history of prior VTE, active cancer, or a concurrent silent DVT-PE. This Class 2B recommendation is based on consensus and observational data, identifying features that might warrant longer treatment, though the best extended duration or agent isn't as clear as the initial 45 days.
What about SVT that's less than 3 centimeters from the deep junction? Really close.
For SVT less than 3 centimeters from the junction, the guideline recommends treating these patients essentially as if they have a DVT. That means full-dose anticoagulation typically for 3 months, because the risk of extension into the deep system is considered very high.
And for really short SVTs, less than 5 centimeters long.
The guideline notes a lack of evidence here. It suggests expectant management, watchful waiting, might be okay in low-risk patients, but anticoagulation should be considered in higher-risk patients. For SVT longer than 5 centimeters, they mention considering therapeutic or intermediate dose anticoagulation for longer initially, maybe switching to prophylactic later for a total of 3 months in high-risk cases, but they admit there's little evidence to support doing this routinely just based on length.
Figure 5 provides that helpful flowchart for VTE. It branches DVT versus SVT. DVT leads to full-dose DOACs, Class 1 for 3 months, then consider extended DOAC preferred, Class 2A, noting the APS exception. SVT branches on distance from junction. 3 centimeters means treat like DVT, full-dose AC. Footnotes cover considering extended therapy for high-risk SVT features.
Right, micro recap on SVT. SVT 3 centimeters from the deep junction gets treated with full-dose anticoagulation like a DVT. SVT equals 3 centimeters from the junction gets prophylactic dose fondaparinux or LMWH recommended, Class 1, Level B, or prophylactic Rivaroxaban may be considered Class 2B, Level C. Recommended duration is 45 days, Class 1, Level A. Extending therapy may be considered Class 2B for specific high-risk features.
Section 5.4 addresses cancer-associated venous thromboembolic events. That's strong link. Trousseau syndrome.
Yeah, cancer patients have about a 7-fold increased risk of VTE, highest in the first few months. And getting a cancer-associated VTE is linked to lower 1-year survival.
For treatment, LMWHs were the standard for a long time, but DOACs are now preferred for many.
Yes. The guideline discusses trials like SELECT-ED, Rivaroxaban versus LMWH, HOCUS-I VT cancer, edoxaban versus LMWH, and Amplify subgroups, apixaban versus LMWH. These generally showed specific DOACs, Rivaroxaban, edoxaban, apixaban, were non-inferior, or maybe even better than LMWH for preventing recurrent VTE. Some trials, particularly with Rivaroxaban and edoxaban, did raise concerns about potentially higher rates of GI or GU bleeding compared to LMWH in certain cancer types, like active GI cancers.
So based on that evidence, what's the preferred approach now for cancer-associated VTE?
Recommendation 72 is Class 1, Level A, providing a strong recommendation. It recommends direct oral anticoagulants, specifically apixaban or Rivaroxaban, for at least 6 months over low molecular weight heparin or vitamin K antagonist for most patients with cancer-associated venous thromboembolism. This is based on Level A evidence showing comparable efficacy, generally acceptable safety, and better convenience.
And if DOACs aren't suitable for a particular patient with cancer-associated VTE?
Recommendation 73 is Class 2A, Level A. It says you should consider low molecular weight heparin for cancer-associated VTE if direct oral anticoagulants are contraindicated or not suitable. Examples might be those GI-GU cancers with high bleeding risk, certain drug interactions, or significant renal impairment. This Class 2A recommendation is still supported by Level A evidence for LMWH's established efficacy, providing the standard alternative.
Okay, micro recap on cancer-associated VTE. DOACs, apixaban or Rivaroxaban, are recommended first choice for at least 6 months for most patients, Class 1, Level A. LMWH should be considered as the alternative if DOACs are unsuitable, Class 2A, Level A.
Section 5.5 covers periprocedural antithrombotics for venous intervention. This includes things like superficial vein ablation or interventions for deep vein disease.
Starting with superficial and deep venous surgery, what about VTE prophylaxis for vein procedures?
Recommendation 74 is Class 2A, Level C. It addresses patients having endovenous ablation of the great saphenous vein for superficial incompetence. It says you should consider thromboprophylaxis with a low molecular weight heparin for these patients if they are thought to be at higher risk of deep vein thrombosis. This is based on consensus, Level C, acknowledging that while the overall post-op DVT risk might be low, there's a subgroup with higher baseline risk who might benefit from prophylaxis.
Section 5.5.3 focuses on interventions for deep vein thrombosis and chronic obstructive lesions like thrombectomy or thrombolysis for acute DVT or venous stenting for chronic blockages.
The guideline notes that standard anticoagulation is generally continued or started after mechanical thrombectomy or lysis for acute DVT. For provoked DVT treated with intervention, anticoagulation might switch to antiplatelets after 3 months. However, for venous stenting specifically, whether acute or chronic, the guideline really emphasizes a significant lack of randomized controlled trial evidence to define the best antithrombotic strategy and duration.
They mention a recent consensus statement suggesting LMWH then warfarin after acute deep vein intervention and warfarin or a DOAC after intervention for chronic deep vein disease.
Yes. They also note anecdotal reports of venous stent thrombosis happening on DOACs, although the general expectation is DOACs should work similarly to warfarin for DVT treatment overall. The guideline adds that continuing antithrombotics post-op is common, and indefinite anticoagulation is often recommended for most post-thrombotic patients anyway. But the specific strategy and duration after venous stenting remains an area with limited high-level evidence.
Finally, Section 5.6 discusses venous malformations. These rare conditions involve abnormal veins, sometimes with localized clotting issues, risking both thrombosis and bleeding. Klippel-Trenaunay syndrome is a known example.
Right, these conditions can have thrombosis within the malformed vessels and sometimes a localized coagulopathy. The guideline mentions a panel recommendation for prophylactic anticoagulation in Klippel-Trenaunay patients with extensive malformations, especially with a marginal vein if the VTE risk seems high.
And they note some emerging data suggesting DOACs might help markers of localized coagulopathy, although it's off-label use.
Yes, preliminary data on D-dimer and fibrinogen. Based on the risk of coagulopathy worsening during procedures, recommendation 77 is Class 2B Level C. It says you may consider prophylactic anticoagulation, LMWH or DOAC, for 10 days before and 20 days after any invasive procedure for patients with extensive venous malformation or Klippel-Trenaunay with evidence of localized intravascular coagulopathy, like low fibrinogen high D-dimer. The goal is preventing progression to DIC. This Class 2B recommendation is based on consensus for this rare, complex situation.
And what about using antiplatelets for these patients?
Recommendation 78 is Class 3, Level C. It is not recommended to use antiplatelet agents to bring progression to DIC in patients with venous malformation-associated coagulopathy. Also, based on consensus, suggesting antiplatelets aren't the right tool for this specific problem. Okay, quick micro recap on peri-procedural venous interventions and venous malformations. Thromboprophylaxis with LMWH should be considered Class 2A Level C for higher-risk patients getting superficial vein ablation. For DVT chronic obstruction interventions, including stenting, standard anticoagulation principles apply, but the ideal strategy after venous stenting lacks robust trial evidence. For venous malformations with localized coagulopathy, prophylactic anticoagulation peri-procedure may be considered Class 2B Level C for extensive cases with coagulopathy markers. Antiplatelets are not recommended Class 3 Level C.
Okay, let's take a mega recap of the entire Section 5 on venous disease management. We started with VTE prophylaxis, recommending individualized risk assessment, Class 1. For proximal DVT, full-dose DOACs are recommended over VKAs for the 3-month principal phase, Class 1 Level A, and also preferred for extended therapy, Class 2A. Aspirin not recommended for extended VTE prevention if AC is an option, Class 3. For SVT, if 3 centimeters from deep junction, treat like DVT, full-dose AC. If 3 centimeters from junction, prophylactic fondaparinux LMWH recommended, Class 1, or prophylactic Rivaroxaban may be considered, Class 2B, for 45 days recommended, Class 1. Extended therapy may be considered, Class 2B, for high-risk features. For cancer-associated VTE, DOACs, apixaban Rivaroxaban, recommended first choice for at least 6 months, Class 1 Level A, LMWH alternative, Class 2A. Peri-procedurally, LMWH thromboprophylaxis should be considered for high-risk superficial ablation, Class 2A. Specific strategy after venous stenting lacks trial evidence. For venous malformations with localized coagulopathy, prophylactic AC peri-procedure may be considered Class 2B, antiplatelets not recommended, Class 3.
We have covered an enormous amount of ground, from measurement techniques through the intricacies of arterial disease management across different beds and scenarios, and now through the key aspects of venous disease treatment and prevention. Now let's look at Section 7, Unresolved Issues and Future Research. This is really important because it flags where the current evidence falls short and where we need to go next.
One of the first big points they raise is about the lack of patient involvement in trial design. This can lead to studies focusing on endpoints that, maybe matter more to clinicians than patients, things like composite outcomes that vary between trials, making comparisons hard rather than focusing on quality of life or patient-reported outcomes.
Right. And they also call for standardizing antithrombotic protocols within clinical trials, especially for new interventions like endovascular devices. This would help avoid confounding the results and make comparisons more reliable.
Large prospective registries like SweetPad are highlighted as potentially powerful tools for future research.
Definitely. They can be used for large observational studies, especially for rare conditions, and also as platforms for more efficient registry-based randomized controlled trials.
The Guideline Committee then lists several specific research recommendations. What are some key areas they pinpointed?
Well, first, they strongly advocate for incorporating patient-centered outcomes and involving patients in trial design. They want standardized definitions for composite endpoints and standardized antithrombotic protocols in intervention trials, maybe using core outcome sets.
Facilitating those registry-based RCTs is another key point.
Absolutely. And a really critical gap they identified is the need for better, validated bleeding risk assessment tools, specifically for PAD and venous disease patients. They developed the OAC3 PAD score for this guideline, but more work and validation are needed. This is crucial for true shared decision-making about risk-benefit.
So research needs include developing and validating bleeding scores, improving how we define and measure major bleeding, ideally from the patient's perspective, and defining net clinical benefit considering multiple viewpoints.
Exactly. And remember, platelet function testing. They explicitly call for more clinical studies to see if actually testing for and treating high-on treatment platelet reactivity in PAD patients, especially high-risk ones, actually improves clinical outcomes. We need to know if acting on the test makes a difference.
They also point to specific gaps, like needing studies on antithrombotics for upper limb arterial disease, and for asymptomatic or intervened visceral artery disease, maybe using cohort studies.
And more research is definitely needed after lower limb revascularization. They want RCTs comparing different strategies after bypass, especially in high-risk groups or below-the-knee grafts. And surprisingly, they note the lack of good data on antiplatelets for aneurysms like AAA, suggesting RCPs are needed there.
Managing isolated thrombus in the aorta or a stent graft is another area flagged as needing evidence.
On the venous side, they asked for research on intermediate doses of LMWH versus placebo for SVT. They also want RCTs to figure out the best treatment duration for SVT near a junction, beyond the current 45 days, and better evidence generally on the optimal duration of extended anticoagulation after SVT.
And finally, they highlight the need for clinical studies on antithrombotics, specifically before, during, and after venous stenting, suggesting collaborations might be needed here.
These research questions really represent the cutting edge, highlighting where our current knowledge is limited and where future efforts need to focus to improve care. It's essentially a research agenda for the field.
That brings us to the final section discussed, Section 8, Plain Language Summary and Information for Patients. Now, obviously, this wasn't written for us clinicians, but looking at how they distilled all this complexity for patients is really valuable for framing our own conversations.
Absolutely. It breaks down the core concepts very simply. It explains what antithrombotics are blood thinners and how they work, using that analogy of platelets being the first step, stopped by antiplatelets, and the clotting cascade being interrupted by anticoagulants.
It clarifies why patients need them to lower the risk of clots causing major problems like strokes, heart attacks, or leg issues.
And it tackles the bleeding risk head-on, mentions bruising, but also stomach bleeding, while noting life-threatening bleeding is rare. It emphasizes that anticoagulants generally carry a higher bleeding risk than antiplatelets.
The core concept of balancing clot prevention against bleeding risk is central, and the importance of shared decision-making is stressed, acknowledging the patient's perspective on risk might differ from ours.
They even mention the difficulty in predicting bleeding, saying there's no good way to clearly predict who is going to bleed other than if they have bled before, which echoes the research gaps we just discussed. And they list practical steps to reduce risk, like using PPIs for stomach protection if needed.
For arterial diseases, the summary tells patients most with symptoms need lifelong antiplatelets. It simplifies the specifics for brain arteries, short-term stronger treatment than single for minor stroke high-risk TIA, and leg arteries, none if asymptomatic, single or combo if symptomatic, depending on risk. Peri-procedure options vary. For AAA, aspirin considered for small, lifelong after repair, and it touches on coordinating care if patients are on blood thinners for other reasons.
For venous diseases, it explains anticoagulants are usually needed for a few months. Duration depends on clot seriousness and risk balance. For vein procedures, the need for blood thinners varies based on risk.
This section really serves as a great model for us. It translates all the complex data and recommendations into clear, patient-friendly language, focusing on the why and the risk-benefit balance.
It does. It's a good reminder that ultimately our job is to take all this evidence and apply it meaningfully to the individual sitting in front of us.
Well, we have certainly gone through an immense amount of detail from these guidelines, covering such a wide range of vascular conditions, treatments, and patient factors.
It really underscores just how complex antithrombotic therapy is across the whole field of vascular disease. These guidelines provide a really comprehensive evidence-based framework, but as we saw, they also clearly highlight where the evidence is still thin or lacking.
This deep dive was designed specifically to give you, the specialist clinician listening, a detailed evidence-based walkthrough of these crucial recommendations, hopefully providing insights into the rationale and the clinical nuances that inform your daily practice and your conversations with patients.
And as the guidelines themselves point out, that challenge of applying evidence often generated in these very carefully selected trial cohorts to the messy reality of managing individual patients in everyday practice with all their diverse risks, comorbidities, and priorities. Well, that remains a central ongoing task for all of us in the field.
And that brings us to our final provocative thought for you to ponder as you reflect on this deep dive. Given the acknowledged lack of validated bleeding risk scores specifically tailored for many of the patient populations we've discussed, the documented differences in bleeding risk between those highly selected trial participants and our real-world patients, and the ongoing challenges in standardizing trial protocols and capturing patient-centered outcomes, how can we, as specialist clinicians, best navigate and bridge that gap? How do we optimally blend the often precise yet limited evidence from randomized trials with the complex, individualized decisions required when managing real-world patients, considering their unique risk profiles and their personal values? It's a question that really sits right at the intersection of evidence-based medicine and the art of clinical practice.
Indeed, it's what we grapple with every day.
Thank you for joining us for this deep dive into the ESVS antithrombotic guidelines.